Hey, welcome to episode 27 of the Go-To Physio podcast. In today's episode, we talk about the upper limb and in particular the importance of the biceps, triceps and flexors of the forearm to help the shoulder be successful. I hope you enjoy the show. Hey, welcome to episode number 26 of the Go-To Physio podcast. And today we're talking about what we've covered in module 3 of the Go-To Therapist Mentorship, which is the assessment, treatment and low to mid-level rehab of the upper limb. So this week, the therapists really got their thinking, their clinical reasoning challenged, and module 3 is really where we really differentiate ourselves from other therapists in that we look at the upper limb very, very differently to how I was taught in university, and certainly very, very different to the majority of even external additional CPD courses are being taught. So how we look at the upper limb, it it was slow developing. It took time, and it it's still developing. If I'm being completely honest, the further clarity I get, the progressions, the regressions, they've come a long, long way, even in the last 12 months. And the more we expose this way of looking at the body, just like anything, it naturally evolves. And the nice thing about it is therapists on the mentorship, especially the refresher courses, they share with us how they've kind of been kind of taking the principles and using them, and that obviously kind of sparks ideas for myself. I may not necessarily use the exercise that they've kind of shown me, but sometimes I do. But sometimes what I will do for me is go, actually, I really like that, and then we'll take that and develop it further, really. So some of the big differences that we look at in the upper limb is, I don't really worry too much about the rotator cuff. I don't worry too much about the scapula stabilizers, if I'm being completely honest, with upper limbs. Okay, now I've had a lot of people. This method, this approach is being tried and tested. Okay, so being very respectful, I've had a lot of rugby players, in particular Union and League, who have come to me, who have been around the houses, who have seen some of the top shoulder therapists around me, therapists who are teaching courses, um, therapists who've written book chapters on shoulders that they haven't been able to help. And when we use this approach to them, we can get very, very good results with them, consistently and predictably. Okay, if now a big if, the assessment shows up that there is some stuff that we need to improve on. Now, of course, there will always, I'll never say, it will always help, because sometimes there'll be pathology there, obviously, that may be just a little bit too much. But certainly with this approach, it's been able to get us very consistent results. Now, what I don't focus too much on, as I said, is the rotator cuff and the scapula stabilizer. So again, with a lot of shoulder issues, if you think of when people struggle with their shoulder, they might get pain lifting their hand overhead, they might get pain lifting a cup up, etc. Then the intent always, it's not to move from the shoulder.
Hey, I hope you're enjoying today's show. For more clinical content and tips to help you implement this content in the real world, please visit thegotophysio.com for more information, including my 6-step patient adherence checklist, which you can download for free. And also there's more blog content that helps you implement this stuff in the real world. You'll also find links to my YouTube show, the Go-To Physio Show, as well as lots of more information to help you become the go-to therapist, helping real patients get real results in the real world.
Okay, so when we go to lift our arm overhead, the intent is to lead with the fingertips. Okay, if I got to reach for something overhead in the cupboard, my intent is always leading with the fingertips. Okay, so what we've done in the mentorship is we've basically taken the lower limb return to play course, and then we've made a commitment to look at the upper limb the exact same. Now, there's two or three very, very important muscles that have to do a great job in transferring energy, and that is the biarticular muscles. So just like the hamstring and quad and the gastroc very important to transfer energy in the lower limb. The bicep, tricep, and the wrist flexors are very, very important as well. And we look at the anatomical makeup of these tissues. The flexors, they've got long tendons, and again, we know, developing as babies, etc., when we are crawling, these tendons are designed to transfer energy, okay, to make us more efficient, to use less energy to do the same tasks, okay, if you want to talk about energy efficiency. So what we do in the mentorship is we focus on allowing these tissues to do their job, to give the deltoid time to contract, build tension, just like we delay knee extension with the hamstring and the quad and the gastro co-contracting, to allow the glute max to time to develop tension to do work. We do the exact same with the deltoid, because it doesn't make sense in my mind that you got this little muscle, these tiny little muscles, supraspinatus, infraspinatus, etc., and you've got a massive deltoid, you've got a massive bicep, you got a massive tricep, you got a lat, you got a pec, you got all these big muscles, a lot of uniarticular muscles whose jobs are to produce force, okay, and to do work. It doesn't make sense that, for me, that the vast majority of people shoulder problems are down to these small little muscles, okay, not doing their job. For me, from my experience, my opinion, which again, I'm not saying, I'm very, very open to being disproven, and and learning from it. That's absolutely fine. But for me, a lot of the time, the rotator cuff, it's overloaded, just like tendons, etc., weak because of pain, because of overloading. Okay, so again, I've no doubt that people are getting results when they do a lot of these exercises, but I would question why they're getting a lot of these results. Okay, so again, when we do a lot of rotator cuff exercises, there's a lot of other stuff happening as well. You're training a co-contraction of the elbow, you're training an ability of the deltoid to produce force, etc. Okay, the posterior deltoid, especially, not that's a portion of tissues I see a lot of issues with a lot of people, post rotator cuff tears, especially. Okay, and I've rehabbed a lot of these in the rugby setting as well. So that's one thing that we focus a lot on, and that kind of therapist again the heads around in the mentorship this week is how to assess the energy transference ability, if you want, for want of a better word, across the upper limb, how to co-contract at the wrist, the elbow, and the shoulder, and then also to then go up and towards the shoulder blade, rather than worrying too much about the scapula and trying to get the scapula to retract and posteriorly tilt and do all these kind of things that certainly I was taught in university. Is instead of that, is actually looking at the ability of the rib cage to retract and allow the scapula to be sat on a rib cage that ultimately gives it a stable anchor, so to speak. Okay, so rather than shooting a bazooka out of a canoe, is that we give that scapula a little bit of stability. We give it a good surface to sit on. So again, for me, a lot of scapula issues, once we get that rib cage to retract, we can get a lot of much better length tension relationships for a lot of these tissues. Now again, it might be one, it might be both of those things that I've talked about today. It might be a whole combination, but that's certainly something that I think is very new to a lot of the therapists. They seem to be gripping it well. There's not module two. There's a lot of content in it. And again, the thought process, the clinical reasoning. Whereas this nice module three, there's not as much kind of content to get through. And the shoulders actually, it becomes very, very simple, very, very straightforward, and we can ease people's symptoms, and we can get them up that great exposure ladder very, very quickly. So that's what's been happening in the mentorship this week. As I said, it's a very different way of looking at the body, and it's a way that we can easily get therapists to differentiate themselves from other therapists and help a lot of people with shoulder pain that have failed traditional approaches. And when we work up to great exposure, then we're spending a lot of time looking at it 10 through the fingers, looking at co-contractions at the elbow, co-contractions at the wrist, to give that rotator cuff an ability to work with the deltoid, to work with the traps, to work with the rib cage, for everything to do its job, as opposed to just trying to isolate or recruit a tiny little muscle. It just doesn't make sense, or it doesn't sit well with me. And as I said, I've got no doubt doing rotator cuff exercises helps a lot of people, but the more important question for me is what else is happening when we're doing a lot of these exercises. Okay, now most importantly, I think when we do a lot of these exercises, if we're saying that actually, the co-contraction is the elbow, posterior delt, then what's very important is we need to look at the length tension relationships of the bicep tricep with a lot of these exercises. So we can tweak a lot of these exercises. We can take a lot of the good things that's happening, and we can make them a little bit more specific to length tension relationships of that person's aggravating and easing factors, and learn a lot from it. And if you head over to www.thegotophysio.com/blog, also make sure you check out my blog post on the intent of the fingertips for your traditional rotator cuff exercises as well. So head over there after this podcast and check out that video as well. And there's a previous podcast episode on that. Okay, so short and sweet this week. I'm just in London at the moment, so about to go into England camp again, play Ireland this week in the Six Nations. So looking forward to that, obviously, for obvious reasons. So now it's time for me to switch my head back on to applying the content in the real world, rather than teaching. So as I said, everything that we do in the mentorship I use. Everything I teach, I try test. I look for long-term changes. It's not theory. Everything that, as I said, is being tried and tested with both professional athletes and therapists in the clinic, so that there's no fluff. Okay, so that's it for this week. Next week we move on to the lumbar spine, and again, lots to talk about there in terms of the pelvic floor, the diaphragm, the rib cage, and I've also got a special PDF on the diaphragm and pelvic floor launching very, very soon as well. It's a cheat sheet that I made for the therapist mentorship class, but I'm also going to be making it available very soon to therapists outside the mentorship community for a limited time. So head over to www.thegotophysio.com/blog, where you can pick up the rotator cuff previous article and loads more content there as well to help you get the confidence and clarity to differentiate yourself from other therapists, help people that have failed traditional approaches, and become that go-to therapist. I'll speak to you soon.
Hey, I hope you enjoyed today's show. For more information, please visit www.thegotophysio.com, where you can download my 6-step patient adherence checklist absolutely free, as well as read the accompanying blog that goes with today's episode. We've got lots of cheat sheets and clinical content to help you implement to get real world results with real patients, that ultimately helps you become the go-to therapist and allows you to build a profitable, busy private practice, or become that go-to therapist in professional sport. I'll speak to you soon on the next episode.